Good evening, everyone. Thank you for joining the APPN webinar on non-medical prescribing. We will just continue to let a few more people in, so we'll begin in a couple of minutes. Good evening, everyone, and welcome to the APPN webinar on non-medical prescribing. So just a reminder for everybody to mute themselves, and if your camera's not already turned off, unless you're speaking, please turn that off. So I'm Yogita Stokes. I am the previous Diversity Officer for the APPN, and I will be co-hosting your webinar today with Di Reed.
Thank you. Just unmuting myself. Yeah, hi and good evening, everyone, and thanks so much for joining us. I am the Honorary Education Officer for the APPN, so we're really excited to have you join us this evening.
Thank you, Di. So we'll just go through the agenda for this evening. So just a little bit of housekeeping. So what we would like you to do is probably put your questions and answers as we go along into the chat function, and we will do the question and answer session at the end of the talks. We have 5 talks today, and we have 1 pre-recorded talk for Pip White at the CSP. This webinar this evening is for advanced practice physios and also trainee APs who want to learn more about non-medical prescribing and how they can use this in their speciality. It's also for those that are already prescribing and want to develop their knowledge and their history taking around prescribing and de-prescribing in areas such as pain management and frailty. We have a really great range of speakers today from medical and non-medical backgrounds. Just a quick reminder, if you need to use captions for text options, please go to the 3 dots on the right of your screen and adjust your settings. The webinar will run from 6 till 8 p.m. And at the end, we will be joined by Dave Baker, who is an AP in private practice, an ultrasonographer, and also chair of the ACPOMIT Clinical Interest Group, who will be joining the other speakers to answer questions. Please do use X or Twitter, and these are our Twitter handles throughout the webinar. You know, share any content, any thoughts, anything like that. That would be really great. So we're now going to move on to the first speaker. Apologies. So we're just going to do a quick poll. So I'll just hand over to Di, and she will just do a few questions which you can answer through Teams just to see who we have in the audience today.
Okay, so I'm hoping that the polls will load in the chat. Oops, I can't see them there. I'm just going to ask Melanie. Melanie, are you there? Can you launch the polls?
I am, Di, so you just let me know when, and I'll pop them on.
Would you do them now? That would be amazing. So
come, one at a time. Yeah, okay.
That would be
yeah, okay.
Fantastic. Thank you so much. Okay, so firstly, really, the polls really help us understand who we've got in the meeting today, also around your prescribing practice. So we'll just wait for the first one to arrive. Okay, so can you see that in the polls section? So the first question, you get to let me know if you can, so you can see it. Thank you very much. Thumbs up. So first question, so if you answer into the poll, so what is your base profession? So physiotherapy, medical professional, nurse, or other AHP. So you could complete that now. Okay, so when I look at the results there, I think mainly physiotherapists. Okie dokie. Can we go to the next question, Mel?
Yeah, no problems. Here it comes.
Okie dokie. So that should be showing, I hope. So next question, what's your agenda for change or equivalent banding? We recognise not everybody will work within the NHS. So equivalent banding, so band 6, band 7, band 8A, which obviously traditionally is ACP, band 8B or 8C and above. Okay, so we've got a bit of a range, 8As, 8Bs, some 7s, some 6s. Fantastic. Lovely. Can we go to the next question, Mel? Hoping this will show. Okay, so yeah, next question. So what is your area of clinical specialism? So I can see we've got responses already showing on this. So MSK. Some pain management, frailty, spine, geriatrics, frailty, neuro rehab, rheumatology. Okay, neuro, fantastic, so a range. Lovely. Can we go to the next question, Mel? Okay, so the next question should be showing. So this is, are you, I'm waiting for it to come up for me. Okay, are you a non-medical prescriber, a trainee non-medical prescriber, or you're not a trainee or a qualified NMP? Wow, quite a lot of prescribers and trainee NMPs. Fantastic. Okay, can we launch the next question, Mel? Wonderful. Okay, so how frequently do you use your prescribing knowledge in practice? So this is not necessarily about issue of prescription, but how often do you use your knowledge, your prescribing knowledge? So a bit of a range, but often and sometimes are the majority. Okay, can we go to question 6, Mel? Just waiting for it to load for me. Okay, so last question. So how frequently do you prescribe? So actually sort of issue a prescription. Okay, so interesting results. So a bit of a range, some often, quite a few often, sometimes, but also some rare and some never. So that's really interesting. Okay, fantastic. So just looking through those, so majority of you today are from physiotherapy, of 2% from medical profession, other AHP 2%. Majority sort of bands 8s, 7s and 8s. Okay, clinical specialism, there is a range, but obviously MSK predominant is still at the middle, but there is a range, which is lovely to see. Quite a lot of prescribers, and a range of how often we're actually using that knowledge, and also issue a prescription. Thank you very much. Okay, so I'm going to hand back over to Yogita. So no, I'm going to actually introduce Alex next on type. We're going on to Alex next, are we, Yogita?
Yes, Di.
Okay, brilliant. Okay, well, I'm going to thank you for everyone for that. It's really useful for us to know who's joining us today and around your experience as well. So I'm going to introduce the first speaker. So if we could just move the slides on, that would be fantastic. And Alex, if you want to show your camera. So our first speaker is Alex Dush. He is an advanced practitioner working in pain management in Dudley. And his talk today and presentation today is on his NMP journey. So I shall hand over to you, Alex.
Thanks, Di. And thank you for inviting me to talk today. So as Di said, and Yogita has put on the agenda, I'm going to be talking about my journey in non-medical prescribing, and about the processes that I went through when doing the course. Okay, next slide. So a bit of background of where I work. I work in pain management at Dudley Group of Foundation Trust. It's an MDT consisting mainly of consultants, psychologists, physiotherapists, pharmacists, and occupational therapists, as well as nurses. We provide services for chronic pain management MDTs, as well as follow-ups, acute pain ward rounds, pain interventions, pain management groups, including FRP, PMP, and mindfulness, as well as referral to physiotherapy and other services. Okay, next slide. So within the service, we looked at why a non-medical prescribing role would be needed. So we assessed the need for it in MDT to help increase knowledge and understanding of medications that were being recommended. We don't necessarily physically prescribe as often in MDT clinics because it's all advised towards the GP, because they're the ones who's going to be continuing the prescription. But still, it's having the understanding and knowledge of the medications that you're recommending in clinic, and occasionally you will have to issue a prescription as well if it's necessary. A part of my role includes ward rounds, so is looking at acute pain on ward rounds, and this is where the majority of my prescriptions are done. So it's prescribing as required to help with pain management on ward rounds. And again, this was one of the main reasons that I underwent my NMP training. Interventions as well. So I am an injector, so having the ability to be able to prescribe medication for injection, as well as providing medications for other people doing interventions such as Cadenza or Botox. Having an NMP who is able to prescribe is useful, as it means that we're not having to wait for a consultant to do the prescription for us. As well as education as well, so providing other AHPs or other members of staff within the trust regarding the use of pain medication and the safe prescriptions of that. Next slide. So within our trust, this is an NMP support flow chart for new or qualified NMP prescribers who are coming into the trust, and it just shows the support that we have and should need as a prescriber in our trust. If you're coming in as a prescriber but new to a different specialty, we stipulate it's important to have enough of a background around the area that you're prescribing in, and having a prescriber, a designated prescriber practitioner available to have supervisions for. The reason why that's important is because within our trust you have a formulary that you follow, that you prescribe off. and it's important that you don't prescribe out of that formulary with regards to sort of insurance purposes. Next slide. I found it a massive learning curve. So I qualified in 2021 as a non-medical prescriber, independent and supplementary. It's a learning curve because it was different to what I expected it to be. You had a big range of prescribing that you were taught about for cardiology, respiratory, and there's a small amount on pain management as well. So I suppose one of the biggest things that I took away from this is that you might not get all the information that you needed on the prescribing that you're going to be doing, and that's why it's really important that could you just press again, Yukita, and again please. So as I said, it prescribes a good basics in all areas of prescribing, but the key takeaways is to get as much variety in your learning practice hours as you can. So that is trying to get into consultant clinics or other NMP clinics within your specialty and out of your specialty as well, to get as big an area, as broader area of understanding about medications as possible. I remember particularly spending some time with a pharmacist, and I found that particularly useful because they know an awful lot about medications, and they could go over a lot about sort of the pharmacokinetics and dynamics, which actually took a little bit of time for me to get my head around. The other thing that I really took away is auditing. So the importance of audit, and I will touch on that a little bit later on, as well as the importance of CPD discussions with other NMPs. And could we go to the next slide? Thank you. One of the biggest limitations I have found is the limited number of controlled drugs that physiotherapists are allowed to prescribe. I'm sure you could all appreciate that working in pain management, you do talk about and want to prescribe other opioid medication or other controlled drug medications, including pregabalin, gabapentin, which we cannot prescribe at this moment in time. But this also includes stopping it. So a big part of pain management is deprescribing. But on board, we're not allowed to stop those medications as we need to. So it is again delaying some of the advice that we're giving, although the ward doctors can facilitate that. In some cases, using a clinical management plan utilizes the supplementary part of my prescribing qualification, which means that we can get around some of the limitations. But again, this is patient specific. So a clinical management plan is an agreement between yourself, a patient, and your prescribing supervisor that you're able to prescribe this medication, which isn't in your which you're not allowed to prescribe independently. If we go to the next slide, please. And that's an example of the clinical management plan performer in our trust. And one of the reasons I use at the moment is for the drugs used in our intrathecal pump refills. It is not it's not available for me to prescribe as an independent prescriber, but because we see these patients regularly, we deemed it necessary to have a clinical management plan. That means that I can prescribe it for myself and the rest of the team. Okay, next slide. One of the big requirements, I think, is know your formulary, know the list of your drugs that you are going to prescribe, and make sure that you have enough background information about those drugs that you can prescribe them comfortably. With review of your prescribing review of your prescribing to look for any incidents or themes or trends of your prescribing practice. This means that you can then take action on this. Okay, and look for any areas that you can improve on or discuss with your prescribing supervisor. Okay, and have regular supervisor meetings. I'm really lucky because I work with my supervisor in clinic every week. That means that we can have discussions on an ad hoc basis, but we still have a formal supervisor meeting every 4 months, which means that we can then discuss in detail any issues that are arising. Next slide. So an example of my audit, and this is probably the most useful thing that I've done since becoming a prescriber, for my own information, is understanding how much you're prescribing or recommending at one time. There seems to be on occasions that you get into a bit of a pattern of your prescribing. So on a ward round, it may be that amitriptyline is the drug of choice of that particular week. But writing down what I'm prescribing tries to stop that and make sure that we're prescribing for the right reasons, and whether it's helping the patient or not. So then you can change your practice and make sure that you're prescribing as appropriately. I've also included on there drugs that I've recommended that I'm not necessarily able to prescribe, such as Butrans, again, from my own knowledge, to see how much medication, how beneficial it would be to have those other drugs on the formulary. With regards to our audit and prescribing in Dudley Trust, we follow the competency framework for all prescribers, which is on the Royal Pharmacy website. It ensures that we're all prescribing to the similar standards. So it's something that I would get yourself familiar with by looking on the website, and it's something you'd aim to sort of follow each time. And each year that we have to look through it and make sure that we're meeting all of those areas. Okay. So deprescribing, I touched on this really briefly, but it's a really important part of my prescribing. It's important to recognise when to prescribe and when not to prescribe. And just because you can prescribe doesn't mean that you should do. But using it to help get people off certain medications is really helpful to do. So always think about the right patient, the right drug, the right dose, the right route, and the right time. But one example of this is patients who come into the pain management clinic or on high doses of particular drugs. One recently would have been on a fentanyl 200 microgram patch. This wasn't prescribed by our pain clinic, but somehow they've managed to get up to high doses. So it's trying to look at alternatives around that and look at how we can try and reduce that medication. One, by getting them off to realise that medication isn't the be-all and end-all of their pain management journey, and looking at alternatives, but also looking at how we can convert that drug, or whether we can de-escalate it and then switch them over to a different medication which might be more effective at that moment in time. Certainly, becoming a non-medical prescriber has given me the confidence to have conversations with patients regarding the medication use and giving them all the information that they need about certain medications, as to why they should be having it or why they shouldn't be having it, as well as giving them all the information about the risks versus benefits of this. So it's really a useful tool to have as a non-medical prescriber, as an advanced practitioner, and it's something that I'd thoroughly recommend to people to do. Thank you very much.
That's great. Thank you very much, Alex. So just a reminder to everybody, we're going to do questions at the end of all the talks. So if you have any questions for Alex regarding his prescribing journey or prescribing in pain management, please put them in the chat, and you can do that as we go along, and we'll look at them in the end. So our next talk is by Ruth Harris. So Ruth is a advanced practitioner pharmacist, and she's going to be talking about deprescribing in frailty. Have we got Ruth?
Hi everyone. Evening. Thanks very much for inviting me to present today. As Geeta kindly mentioned, I'm an advanced practitioner and a pharmacist by background. I work at the Northern Care Alliance in Salford. And I work in our aging and complex medicine department, so I mainly support in the care of our older, frail population. So today I'm going to talk about a little bit of a different angle, so deprescribing in frailty, and bring into that an example of a falls patient who will follow us throughout our presentation. It might be a bit of a whistle-stop tour, and I've tried to cram in as much as I possibly can, because if you leave me enough time to talk about deprescribing, I could be here days after the fact. So we'll bear with me. We'll see how much we can fit in. Next slide, please. Thank you. So deprescribing is a very important and often overlooked part of patient care. After staffing costs, medicines are the second most costly investment the NHS makes. So medicines and medical devices cost NHS England nearly £18 billion a year. And older people are disproportionately high users of medicines. So looking at some of the facts and figures here in front of us, a third of all medicines are prescribed to older people. So 1 in 10 people over the age of 65 takes 8 different medicines a week, and that rises to a quarter of those aged 85 and above. Nearly 10% of all hospital admissions in older persons' care can be attributed to adverse drug reactions, and over half of these are deemed completely avoidable. And just 10 days after being prescribed a new medicine, a third of all patients are not taking that medicine as prescribed or not even taking it at all. And over half of people don't even realise they're doing it. Next slide, please. So most non-medical prescribers are hesitant to prescribe, and it can feel really daunting when you first start. So it's quite reassuring for me to see some of the results of the poll at the beginning here. We know in non-medical prescribing pharmacists, when it has been studied, 50% of those qualified NMPs are actually not prescribing 6 months post-qualification through various different factors. And although it is right to recognise that prescribing is a task that involves an element of risk, nothing we do as healthcare professionals is entirely without risk. And it's not about memorising which enzyme does what to which drug in which organ. Some of the most effective deprescribing or prescribing, it's exactly the same thing, but a mirror image, decisions come from stepping into a patient's shoes and making some common sense decisions, but importantly, in collaboration with your patient. So no decision about me without me. And we need to think about where the medicine, the patient, and the disease meet. And in this presentation, I'm going to go on to discuss each in turn. Next slide, please. At this point, I'd like to introduce you to Mrs. VB, who's a very typical frailty aesthetic patient. So I'm sure some of you that work in frailty might recognise this typical presentation. So she comes to us having had a fall at home. She hasn't quite been the same since a fall she had 4 weeks ago and hasn't been as good on her legs since, she tells us. She recalls this fall really well, the one that's brought her in today, and tells us that she felt dizzy when walking just before her legs gave way completely underneath her, and she found herself sitting on her bottom on the floor. She's mildly frail and relies on her daughter for help with outdoor activities and is otherwise quite socially isolated. Her medicines list, as you can see there on the right, is not an uncommon sight for the sorts of patients that we see. Next slide, please. So unfortunately, we can't get away entirely from pharmacokinetics when talking about deprescribing. But most of the pharmacokinetics and pharmacodynamic information you will look up when making prescribing and deprescribing decisions is based on clinical trial data, where medicines have historically been tested on mainly white, mainly male, working well trial cohorts. And actually, some of this information doesn't immediately translate to all sexes, ethnic backgrounds, or extremes of age. So take all these things with a pinch of salt and think quite pragmatically about the person in front of you. So we know that in older people, the GI tract is slower and the environment is less acidic and less enzyme rich, which means that drug absorption is slowed and often incomplete. Changes in body fat and water composition and reduced efficiency of the vascular system and end organ perfusion alter how far drugs are distributed and where they are stored. And decline in enzyme numbers and metabolic pathways due to decreasing liver size and function means that older people are less able to break down drugs, so they tend to act for longer. And declining kidney function and size mean that drugs can accumulate when they're not excreted at the same speed and to the same extent as they once were. Next slide, please. So arguably more impactful than the physical changes that affect how people handle drugs are the psychological factors that impact if and when people take their medicines. So you might have heard the term compliance in your practice previously, and we've actually moved away from this term because it reinforces quite a paternalistic model of medicine. You know, I make the rules, you must comply. So instead, we actually talk about concordance. And as you can see in the definition here, on the left, it reinforces the importance of a therapeutic relationship between you as the prescriber and your patient. You know, you come to an agreement together about a medicine. You know, you both understand the risks and benefits, and you know, you're both happy to proceed. And what concordance, compliance, whatever you want to call it, doesn't mean necessarily always is blister packs. Next click, please. So being physically or cognitively able to take a medicine is just the tip of the iceberg. Education and socioeconomic deprivation impacts a person's ability and assertion to access resources and information to understand their underlying diagnoses. So this can impact anywhere from a person's capacity to make decisions relating to treatment to even, and given the average adult literacy age of the area in which I practice in Greater Manchester is 7 to 9 years old, you know, it impacts significantly a person's ability to read the dispensing labels or even tackle the patient information leaflet in the box of their medicine. And social network is really important to help engage and motivate people to manage their health and manage their medicines. We know from evidence that loneliness has the same impact on a person's physical health as smoking 20 cigarettes a day does. There's a huge raft of research into the perceptions of health versus illness. You know, and if we have a patient in front of us that doesn't even believe if they're ill to begin with, you know, how easy will it be for us to encourage that person to start taking medicines for a disease they don't think they have? And do they therefore truly understand or believe the potential consequences of non-concordance with treatment? Wrapped up in all of this as well is a patient's belief in medicines. So we know that patients tend to be more concordant with medicines they can actually feel the effects of. So things that reduce their pain, things that make them feel calm and help them to sleep, and not necessarily on things they can't. You know, I've certainly have never had a patient come to me and tell me, you know, they feel, you know, wonderful after the statins reduce their cholesterol, you know, or they can feel the anticoagulant effects of edoxaban working away, you know, and this is why deprescribing things like opiates, benzodiazepines is so challenging. And media, friends and family also have a real significant impact on concordance. You know, my neighbour took that and felt awful, so there's no chance I'm going to, or I read on Facebook, or I read in the Daily Mail X, Y, and Z. And actually, all these things kind of put a barrier up to your consultation from the start that is actually quite challenging to overcome. Next slide, please. So we need to bring together these physical and human factors when approaching decision making with our patients. So the general aim of any treatment is either to maintain a patient's quality of life, improve their longevity and minimize harm. And all of these should be at the least cost of burden to your patient. So quality of life is quite an abstract concept and might mean something very different to the patient than it does to us. So what matters most to them could be anything from making it long enough to see their grandchild graduate or get married, or it could be to squeeze every last possible minute out of living. And providing this decision making is informed, a patient has capacity, and there is no risk of direct harm to a patient from either stopping or continuing the treatment. Respecting what matters most to them is incredibly important, even if it doesn't align with our own thoughts and opinions. And we also need to ensure that when best interest decisions are made on behalf of the patient, when they lack the capacity to decide, to make sure we are doing things in the best interest of the patient and not their next of kin. Effective frailty scoring can assist with pragmatic decision making or goal setting around longevity. So, you know, what are we really looking at? Are we looking at getting a person to live their best last weeks or months or years of life? And sometimes numbers can help illustrate discussions. So numbers needed to treat versus numbers needed to harm data can help support deprescribing discussions. So that might be, you know, 1 in 10 people has to take this to get a good effect. 1 in 5 has to take it to get a side effect. And sometimes quantifying that might help people to understand the risks and benefits. And bearing in mind our earlier discussions about trial evidence of avoiding any medicines where there is limited or dubious evidence base for continuing treatment in your specific patient population. And make sure we know it's clear what this evidence base is actually offering. Are we reducing an immediate risk to the patient or treating immediate symptoms, or are they effects and benefits years off realization? To support informed decision making, there are free and freely available patient decision aid tools, both written and visual aids on the internet. But actually, often it's about engaging in a conversation with your patient and treating it like a negotiation. So, I often have the conversation of, look, I know you're not keen to reduce your pregabalin dose, but bear with me, are you willing at least to reduce it a tiny bit? Let's see you again 25 milligrams less in 2 weeks' time. At that point, you can tell me how you feel, honestly. If you feel worse and it doesn't work, we can step back again. But if actually, you're surprised you don't feel that different, we can carry on and we'll go from there. Next slide, please. Thank you. Another thing to spot when planning to deprescribe is identifying cascade prescribing, and often these can be your easiest wins. So where there is multiple morbidity, there is the risk of prescribing cascade. So this is an actual evidence-based phenomenon which recognises that problematic polypharmacy exists where an adverse drug reaction is misinterpreted as a new condition. So we then prescribe a new drug for it. That then carries its own side effects. We prescribe another drug, and then we get into a vicious circle of medicine on medicine on medicine. Next slide, please. So, for instance, bringing back Mrs. VB to the conversation, when we actually explore more of the history and background to her medicines, we find out that she went to the GP with swollen ankles soon after starting amlodipine, for which she was started on furosemide. So it was assumed she had heart failure. She's an old lady, she's got swollen ankles. She's on a beta blocker and aspirin. This wasn't the case. The furosemide dehydrated her and dropped her blood pressure too far, which led to her having her first fall a few years ago whilst out and about. And this was incredibly traumatic for her, and it led to a really prolonged hospital stay. She became really fearful of falling as a result, and this led her to her staying closer to home, and as a result, she lost her social circle. She was then started on sertraline for the anxiety and low mood that this brought about, alongside some short-term propranolol to bridge the side effects that can occur when starting sertraline, but this was never reviewed or stopped. The beta blocker both masked her hypoglycemia awareness and conveyed central nervous system side effects, which further contributed to her falling. And Mrs. VB was on triple therapy for her diabetes. Each time she went for a review, the computer highlighted her HbA1c as a red result because the computer set to normal HbA1c levels, i.e. those set out in NICE guidelines for the working well general population, rather than adjusted and individualized to her age and degree of frailty. So immediately, on first glance, it was identified that she had under-controlled diabetes, so treatment was added on and on and on. And eventually this included gliclazide, which can cause significant hypoglycemia in old people. She was also started on aspirin and a statin for secondary prevention of cardiovascular disease. Now, back when this was started for her, NICE actually recommended aspirin and statins for this purpose for anyone with diabetes. However, that guidance has now been superseded, and NICE no longer recommend aspirin for this purpose. However, it's one of those medicines where no one really wants to stop it, so it was carried on. She's also been on ferrous sulfate and folic acid for anemia since 2012. And these are the sorts of things that often fly under the radar. So seemingly innocuous medicines hidden in a long list of other stuff, they're only supplements. So how much harm can they do? Well, actually, the abdominal discomfort and cramping and, loose stools and things brought on by the iron tablet is what prompted having buscopan added to regular medicines. And here in front of us, we see a perfect prescribing cascade. Next slide, please. So discerning between these adverse drug reactions and disease progress needs unpicking. So, if it is a disease progression, is this now progressed beyond the evidence base for the medicine? or beyond what the patient can manage anymore. So be that physically or cognitively. A good example of this is something like alendronic acid for prevention of osteoporosis. Although that risk may still exist in a patient, they may no longer be cognitively able to safely take that tablet in accordance with the specific safety instructions, in which case we'll be doing more harm continuing it than we are any good. And thinking about the aims of treatment, are we actively treating a disease that's there, or following guidance to prevent one that might transpire in 5, 10, 15 years? And how relevant is this realistically to someone in 80 or 90 years of age? So statins, talk about them all the time, are a really good example of this. So obviously there's a huge raft of evidence to suggest they convey a 10-year cardiovascular disease risk reduction. But, how relevant is that in someone who may be unlikely to be alive within that time period? Or conversely, if the benefits of statins are evidence for a specific 10-year risk reduction period, how can we justify them carrying on in someone who's been taking them for 20 years, let's say? How can we prove it's doing them any good anymore? Next slide, please. Medicines themselves come in really different forms, strengths, doses, frequencies, and sometimes you can make a huge impact to a patient by doing something really simple. So can we give something that does the same job, but you only need to take it once a day rather than twice? So something like a Pixaban twice a day versus the Doxaban once a day. Is there a medicine that needs extra equipment to give, such as spoons and syringes that, make things more tricky for your patient, or things that require special storage like refrigeration if a patient is, in the unfortunate current climate, struggling to pay their bills? Not taking a medicine at all may be safer than not taking it properly or not having it stored and being stable. Another common issue is PRN, so when required medication in care homes. Are we right to expect carers to recognise when a medicine is required? And actually, in some care homes, their policy actually precludes carers in giving PRN medications at all. So either should we be giving something regularly or not at all? Something to think about. Next slide, please. We talked about deprescribing being a negotiation, and a big part of this is promise versus payoff. So it's important to set honest and realistic expectations of what treatment success is and what it means. So a conversation I have all the time, and I'm sure other speakers are going to talk about today, is in chronic pain. So some of this might be our fault, if I'm honest, as healthcare professionals, because we talk about analgesia being painkillers. And actually, this kind of conveys the impression that someone is going to be 100% pain-free. And actually, we can't promise that to anybody, and we need to be really honest with our patients about it. And there's oftentimes I've found that patients will go back to their GP because they still feel in some pain, or, they weren't aware that they needed to wait a few weeks for something to kick in first. So there's a perception there that their treatment has failed or isn't working. They need more of it. They need a higher dose. And then we get dose and dose and dose escalation of what are really dangerous medications. So we need to sort of weigh up realistic expectations of effect versus potential side effects, increased pill burden, all those things to our patients. So this can not only help deprescribing, but actually prevent prescribing of some medicines that cause a lot of harm in the first place. Next slide, please. There are tons of medicines like this that are implicated in falls risk, and the Royal College of Physicians has curated a huge body of work in the Fall Safe initiative. So one part of that is identifying medicines and attributing a relative risk rating to them. And they actually have a really good part of their bundle that is medicines, safety and falls. That's like a traffic light system, which might help you to highlight which medicines to go for first if you're going to deprescribe for your patients. Essentially, we know that the medicines implicated are those that cause sedation, that cause low blood pressure or rhythm disturbance. They're our biggest culprits. But in the spirit of time, I want to draw your attention to some of the more indirect contributory factors and some of those that were at play for Mrs. VB. So particularly around treatment targets in older people. So as I mentioned previously, if we go back a slide, if that's okay, sorry. I mentioned previously about HbA1c, so the computer sets a black versus red blood result with a threshold of 42 for HbA1c, and we know that blood pressure, the NICE target is less than 140/90. But actually in older people, these targets are relaxed because we know these tight targets are actually increases their risk of mortality. We know that a blood pressure that's too low in older people causes hypoperfusion of the brain and they fall over. And the older people are much more sensitive to hypoglycemia and the dangers of that. So actually putting that into context, in older people, we actually aim for a blood pressure of less than 150 to 160 systolic and a HbA1c target of less than 69. Next slide, please. Thank you. So putting all of that into perspective, and I know it's been a real whistle-stop tour, we could actually turn Mrs. VB's list from the one on the left to the one on the right. Next slide, please. Thank you. So in order to do that, some kind of principles to take away from today is first, recognizing which medicines need to stop, reducing or stopping one thing at a time. That way you can identify the culprit of any negative effects of stopping something more easily. Taper medicines where possible, rather than stopping something outright. If you're not sure, a good rule of thumb is no more than halving a dose at each step. And actually, this is actually really important with some medicines that have withdrawal effects linked to them if stopping suddenly. So like amitriptyline or steroids. Pardon me. Checking for how the patient feels at each step. So set clear review intervals with your patients, check for benefit, check for harm before taking steps to go further. And then make sure your changes are documented clearly, including the rationale for your changes, so that if you don't see your patient again, the next healthcare professional knows exactly what you're doing and why it can pick up from where you left off. Next slide, please. Thank you. The last thing I want to mention to open up the discussion, which again, I think is going to be quite a theme this evening, is around the restrictions placed on physiotherapists and NMPs. So these, I think, as Alex mentioned earlier, apply to both prescribing and de-prescribing. So when I first started as a pharmacist, non-medical prescriber, pharmacists couldn't prescribe any CDs at all, and now we can. And, although, for my opinion, my humble opinion, although it's deemed to be for safety reasons and what have you, I would actually argue sometimes it makes your prescribing less safe when it actually impacts your decision making. What do you do as a physio on your own in clinic when you see a patient on codeine that's causing them harm, and that's not something you can stop yourself? Or when actually codeine would be a safer option, let's say, for a person starting them on a morphine. There are lots of barriers there you can see and potential risks implicated, but I guess that's for a wider discussion. Next slide, please. Thank you for listening today. I hope it's been useful. Thank you.
Thank you, Ruth. That was a brilliant presentation. Thank you so much. I can see that I think it's Rose that's put in the chat about seeing one of the slides once more, but I think we might come back to that at a later point if that's okay, just in the interest of time. But thank you so much, Ruth. Just a reminder for everyone, please put your questions in the chat because we're going to have Q&A at the end. I've just put a note in the chat that if you can't post in the chat, then you can email us at the APPN Physio Outlook email box. Okay, so moving on to our next presenter. So I'm thrilled to introduce Hannah Goddard. She is an advanced practitioner in frailty working in South Warwickshire. So Hannah, would you like to show your screen? Or just share your camera. You don't need to. We can hear you if you can't do that. Just so that I know you're there.
Hi guys. Yeah, hi, my name's Hannah Goddard and I'm an advanced clinical practitioner in frailty. Can I go to the slide if that's okay? Oh, can I go to my slide? Can you hear me? Okay, that's it. So I'm a qualified physiotherapist. I qualified in 2000 from Sheffield Hallam, and I have been a member of the Chartered Society of Physio since 2000. I worked as a respiratory physiotherapist until 2018. In that time, I did a master's degree in physiotherapy at Coventry Uni, and I completed that in 2014, and I had a plan on what to do with it. I just felt like I needed to do it and just get a bit more sort of qualification. From that, I was then invited to do a non-medical prescribing module, or 2 modules at Coventry Uni, which I completed in 2016. And the reason for doing that, it was just to benefit my present role as a respiratory physiotherapist. Although I wasn't doing any prescribing at the time through that, the only thing I was recommending was the odd saline neb, paracetamol or salbutamol neb. From that, I then went on to do the advanced health assessment and decision making. And then an amazing opportunity came at our trust to join the frailty team in 2019 as an ACP, and I went for it, and here I am now. So if we go to the next slide. Okay, so yeah, so join this amazing team. Part of my role as being a frailty ACP is coordinating the frailty take in ED in our South Warwickshire Foundation Trust. How that works is every morning looking down a list of names and ages in our ED and looking for suitable candidates for that. Once we've selected the appropriate patient, we then transfer them to our SDEC area, which is our frailty assessment unit, which is usually free. We can then take the patient and then do our assessments there. How we choose our patient is using the SWFT frailty inclusion criteria, which we have here. So any patient, patients that are age 75, we will consider, particularly ones that have had any recent falls, any diagnosis of dementia or have delirium. If they're from a 24-hour care facility or have maximum package of care at home, so the QDS double ups, we will see. Any new mobility. Not all 75s will be seen. Those that are independent, those that are still driving, we will tend not to see and usually refer on to a specialist. It's normally something like a cardiac issue that might be the cause for this recent illness that they may have. Once we've selected our patients, we then initiate the comprehensive geriatric assessment. Next slide, please. Oh, next slide, please. Okay, so the comprehensive geriatric assessment, for those that are not in the know about this, is basically, carry on, if you wouldn't mind, just get the whole, would you mind clicking the next bit? That's it, great. It's basically a multidimensional interdisciplinary diagnostic process to determine the medical, psychological and functional capabilities of the frail older person in order to develop a coordinated and integrated plan of treatment and long-term follow-up. I mean, that's basically what it is. It's an amazing tool, really, that all the team can get involved in. Not one person will complete this document. It's the MDT, we've got the occupational therapists, the physiotherapists, the admiral nurses, also speech and language. We all contribute to this, the consultants and the ACPs. And it helps to formulate a little bit of a plan for where we're going to go with this particular patient. CGAs have proven to be highly effective. They help to improve on discharge rates, reduce readmission, reduce long-term care, and it also gives patients greater satisfaction as well as their relatives as well. So this is, as Ruth was alluding to in her last presentation, it gives the patient a little bit of empowerment as well. We're able to ask them what their expectations are, get a little bit of sort of a background about what their quality of life is like as well. Okay, thank you. Next slide. Okay, next, and carry on if that's okay. Click on, that's it, thank you. So the comprehensive geriatric assessment basically addresses several things as well, and we look into like polypharmacy. So it gives you the ability to record all the patient's medications and have a look at them and ask questions about them as well, and sort of looking at scheduling of these medications too. It's just ensuring that we get the treatment right and we're able to tailor make our management for that patient. As Ruth mentioned in the last presentation, a lot of our job is prescribing, also de-prescribing the medications. And I will talk about this a little bit later on. Using a CGA also helps with the management of sarcopenia, which is quite evident. It helps with treatable causes for weight loss, helps to look into things that cause exhaustion, depression, anemia and hypertension, plus hypothyroidism and B12 deficiency, which is quite common within this cohort of patients. Also looks into causes of dehydration as well. Next slide, please. Oh, sorry, and social support as well. So we can also sort of deem how much support the patient's getting at home. So how we get the information and how do we get sort of as the sources about what the patient's actually being prescribed. So what I would do is have a look at the patient, get as much information as I can from that individual or from the relatives. I would look at also previous TTO letters as well. Majority of our patients are readmitted back into the system, so they may have a current TTO letter that we can have a look at and see if there's actually been any medical changes to that too. We're also very lucky to have integrated medical records too, so we can look at the communication between the patient and the GP and see if there's been any sort of changes regarding medications or scheduling of the medications. The SCR record is one that I always go to look at the patient's current medications, any acute medications, any discontinuation of the medications. What I am very mindful though is when I'm using the SCR, I always ensure that if patient has had a readmission, I'm also looking at the TTO letter, because often the SCR is not always updated. So you just have to make sure that you've got a sort of a more up-to-date version of what the patient's actually on. Collateral history is very important too, and a lot of the caregivers plus family know a lot about the patient's medications because they're the ones that may be ordering the medication in for the patients that have dementia. So they will have quite a great knowledge of what medications the patients are on, particularly if they have like diabetes. Not always, it's written what sort of units a patient might be taking. So that's where it's important that we find out from the carers or the care home or the relatives what kind of units that they might be on. Amazing, very valuable sources are pharmacists at work as well. So they're brilliant to talk to, get advice about. They can also go and ring up surgeries as well to get the information if the patient is unable to actually communicate what they're actually taking at that precise time. And I'm often bleeping the pharmacist to say, what do you think of this? And could you look into this and see if they're still on this medication? Because often they'll be on a medication that will be noted and they haven't taken it for a number of years. So you want to really make sure that you're as accurate as you can be with what medications they're taking. Okay, next slide, please. I put this slide in because it's a bit sort of just shows you the complexity of the frail patient. The picture shows of a non-frail patient compared to a frail patient with the same condition. And I think it just shows you really, it's not simple as just sort of saying, well, we'll give you some analgesia and then you can go on your way. It's looking at what effect is that going to have on that individual when they already have some predisposing medical condition, and how it's going to affect them, and then also looking at sort of modification of their medications as well to make it more so they can manage this new condition that they may have. So I thought it was a very important slide to show you all. Next slide, please. So I'm just going to introduce you to our frailty assessment unit, which I absolutely love. So our frailty assessment unit is a 15-bedded ward, if you like, which includes 2 side rooms as well. Has 24-hour nurse care, so we're very, very lucky in that respect. As ACPs, we cover it from 8 till 8 at night, so we're there for 12 hours, which is great. It keeps the continuity as well, and it helps with communication. So if we are sending patients to the FAA, we're around for the majority of the day. So if the nurses have any questions about any modifications that we've done to medications, or they've got any queries about medications that we've prescribed, they can come and find us and talk to us, which is excellent. As I said, the last patient admitted to the unit is at 6. It's a single sex protocol, and we very much involve the MDT. So it's not just our decisions that go towards the management of the patient, it's the whole MDT as well. And I find as well, a majority of physiotherapists will actually say to us, have you considered this pain relief? Maybe we should try this before we actually try and get the patient up. So we can have that discussion as well, which is very useful. Next slide, please. So the team, I'll introduce you to our team. So we've got 8 ACPs in the team at Warwick, and 2 of which are trainee ACPs. We're very lucky. We've got 7 care of the elderly consultants who are amazing. The ACPs as well, we've got a great team of ACPs, come with a variety of backgrounds. So we've got physiotherapists, nursing teams, and also we have a pharmacist with us at the moment. So we are very, very lucky. We also have, every day we start off with a designated consultant who joins us for the take, and they're with us for the majority of the day. We have specialist physios and OTs, as I mentioned before. Within the unit, what we tend to do is we will accept direct referrals from paramedics. How we do that is through the Consultant Connect phone. So what they will do is a paramedic will be at home with a patient who's potentially had a fall, is poorly, and they will ring up and then speak to us, and we will offer advice over the phone. And it may be that we can get community links to go to that particular patient, or they need to be admitted to us. But having that information is useful, because then we can start preparing that patient's journey through the hospital. We also have GPs that ring us as well. So they might be in surgery with a frail patient and they want some advice. So we're able to give them advice, and that's the ACPs will give advice, and also the geriatricians will too, whoever has the phone. We also accept direct referrals from our colleagues in the community too, which is very, very useful. And also when we're discharging the patient back to them as well, we keep that communication going as well. As I mentioned, we have direct referrals to the GP. Next slide, please. So this is a list that's going to show in a moment about all the resources that we use for prescribing, which I use on a daily basis. It's not all in my mind, unfortunately. I wish it was. I rely heavily on all of these to get through the day and to get the correct prescribing for my patients. So we use the ILOS medications, which tells you the appropriate antibiotics to use for our particular patients within the region of South Warwickshire. So in different regions throughout the country, it will be different. So if we have a condition, we can click on and we can look up what are the recommended antibiotics for that particular condition. As you can probably sort of figure out, I use the frailty antibiotics a lot. So it would tell me how much I need to be giving and how long for as well. So I find it a very useful resource. We're very lucky as well at Warwick because we have an acute medical local link as well, which is part of our intranet. So the medical team have actually put down guidelines and recommendations, so we can click onto the site, look into documents and look at what the guidelines are for particular prescribing for certain conditions. So we've got patients that have hyperkalemia or hyponatremia. We can look at what we need to be prescribing or deprescribing to ensure that they get back to normal, safe levels with in terms of those electrolytes. Also I use the EMC, and our pharmacists use those as well. So that's I use that a lot when I'm prescribing Pharinject prescriptions for patients that have low iron or ferritin. BMJ stands for reason, and also looking at NICE guidelines as well. Part of all that resources as well is information, but also having a sort of conversation with the consultants as well, and ensuring what they think too, what's their opinion on that. We also, even though we go on those guidelines, we'll also look at the individual patient and see if it's appropriate for their lifestyle and how they're actually presenting too. Next slide, please. So prescribing methods. So this should be a list of all the prescribing methods that we use at South Warwickshire Foundation Trust, if that's okay. I don't know if that's going to come up. So we look at, here we go. So it's electronic prescribing and medical administration is what we use. It's electronic prescribing that we will use, which is very helpful indeed. And we can also, if patients have been admitted into the hospital previously, they may have previous historical documentation of like allergies as well. So we can look at that before we start prescribing. Very rarely now, but we do use cardboard prescription charts. Tends to be used in ED if we're not able to move the patient quick enough to the ward. So we will write on there so that we can sort of start the management in ED, particularly if we've sort of got bed pressures. That's what we tend to do. I use a lot of white scripts as well. So if I've got a patient in ED and I think, right, I can send them straight home, I will then do a white script, get the medication for them and then send them home. So I can put the white script into our pharmacy and get them home straight away. So next slide, please. as you all are aware as physiotherapists, or if you're non-physiotherapists, this is what I came away from university knowing what I could prescribe and what I couldn't prescribe. So initially I was happy with that. I didn't want to really, test my boundaries. I thought I was safe in that. But as I've become more confident, more qualified within frailty, I get a little bit frustrated. There are some medications I can't prescribe. It would be very useful to be able to prescribe them, because I can prescribe them in a timely manner rather than waiting and delaying it and asking for doctors, would you mind prescribing this because I'm unable to. So next slide, please. So again, I've got a list of limitations. So how I find the limitations is within end of life prescribing, so the anticipatory medications. If I and the team deem a patient to be end of life, I then have to go and ask a doctor to prescribe the controlled drugs such as midazolam and morphine through a syringe driver. I'm not permitted to do that. To be honest, I've never had much hitches with that at all. It's never been an issue, but I feel in my heart to heart, I wish I could do that and help and sort of quicken the patient sort of management there. Buprenorphine patches, a lot of our patients come in with buprenorphine patches because of chronic pain. Again, I'm not able to prescribe them, again with the pregabalin, gabalin, the codeine. Another thing that hasn't been discussed is that we can't prescribe units of blood either. A lot of our patients have anemia or have low HB. Again, I have to go through a doctor who may not know the patient, prescribe it. So these are a few of the limitations that I find on a daily basis. So next slide, please. So this is a list of basically how I maintain my competencies. Basically we use the NHS portfolios, and I'm not sure, probably in other trusts do the same thing, where we keep records and reflections on what we've incidents that we've encountered, positive plus incidents where we can learn from. So that's how we can maintain that. I do a lot of reflection as well. So if there's a particularly interesting case that I've been involved in or have had to be involved in the prescribing, I usually will write that up and keep that in in my portfolio for that. I'm not sure if any of you are aware of the Safe Prescriber website and the use of script to help maintain your competencies. The script offer sort of like little tiny mini modules, if you like, with a little quiz at the end of it to see how much you can learn, you learned from it. It covers things like even fluid prescription as well, which is something that we see all the time. We're lucky at Warwick because we have fortnightly teaching with the ACP, so we're always having either doing journal clubs regarding prescribing. We're discussing cases as well, so we meet every fortnight to go through case studies that we've met with. A lot of peer review as well that we have, so we have regular meetings with peers to discuss again case studies. I'm very lucky on a daily basis. I'm working with my supervisor, so we are always discussing cases and patients, and I find the supervisor will always leave me to sort of manage the patient, and then sort of will ask me questions. Why did you come up with that? Why did you come up with that sort of solution, and why are you prescribing this? Why have you thought about this? So that's been very valuable to me, and we're always updated with the antimicrobial modifications as well at Warwick. So next slide, please. That's it from me. So thank you very much for having me.
Thank you so much, Hannah. That was fantastic, and I can see already you're the envy of people in the chat having that many ACPs and consultant in your team. That was fantastic. Thank you so much. Can I just a reminder to everybody, please, any questions in the chat for the Q&A, if you can continue to do that, that'd be great. And also thank you everyone for sharing resources. That's fantastic. We will take those and upload them to our website. I have great pleasure in introducing our next speaker. So Dr. Richard Makin. Dr. Makin is a medical consultant in pain management working in Newcastle, and he's going to talk to us about pain medication and rationale for prescribing. So thank you. I'll hand over to you. Thanks, Richard.
Thanks very much for the invite, Di. So next slide, please. So I'm currently working at Newcastle. I was at Salford for a number of years ago, and Michelle Angus, who's well known to a lot of the delegates, had asked me to give this talk because I'd done some NMP work with the APs and physios at Salford before I left for Newcastle. Next slide, please. As they say in the Verve, the drugs don't work. Next slide, please. And NICE guidelines that came out a few years ago were really quite damning of the role of a lot of medicines. If you look in that red column, you can see that most of the bread and butter of the pain medicines that we did prescribe, opiates, non-steroidals, benzos, gabapentins, et al., most of those are out now. And that's caused quite a bit of controversy. So they're not recommending those are given as de novo prescriptions, which also raises issues about should patients be continuing with legacy prescriptions. And I think there was an excellent talk before talking about that therapeutic collaboration and agreeing whether a drug is the right thing to be on at the right time. Next slide, please. This was one of the things that piqued my interest when I was working in the Northwest. I'm now in the Northeast. I hate to emphasize that there's no connection between the highest opiate prescribing in both those regions and myself. I'm very much a deprescriber. And you can see that Northeast has a startlingly high number of patients. We are chipping away at that in collaboration with pharmacists and GPs in the community and prescribing hubs, doing quite well at the moment. Next slide. And you can see year on year, this is admittedly slightly out of date data, but the trend is over the years, you can see there's been a disproportionate rise of opiates in non-cancer related pain, and that has very much plateaued off now since about 2016, since the Opiates Aware guidelines, which have been really important in changing our practice. Next slide, please. Opiates Aware, if you recall, this is from the Faculty of Pain Medicine and the college. The first time we've kind of introduced a ceiling dose for opiates. That's currently to 120 milligrams a day. This document is going to be revised later on this year. We're now looking at a limit of about 80 to 90 milligrams a day, but there's an evidence base behind why we should restrict opiates to those doses, and there's significant harm associated with higher doses. Next slide, please. And again, phenomena of hyperalgesia, where high doses are associated with more pain, endocrine immune responses, and why that number of 100, 120, there's an inflection point with a significant rise in side effects related to higher doses. Next slide, please. And this is from one of our prescribing leads within the Northeast, highlighting the fall, why opiate prescribing has started to drop. So poor evidence base and some more pragmatic issues are emphasizing the importance of the impaired ability to drive on opiates for a lot of patients, which they're not necessarily aware of, and an increasing issue that I saw both in Manchester and Newcastle, which is diversion, patients selling their drugs as well. Next slide, please. Really important point that's been emphasised by some of the specialists in frailty. Let's not forget the significant impact that opiates have on increasing the risk of falls. So that's both long and short-acting opiates. We can move on to the next slide, please. And some top tips for tapering. This is just for opiates. Reducing slowly when you've agreed with the patient that that's the right thing to do. Who should we be deprescribing on, particularly for opiates? Well, if the medicine isn't particularly helpful, if there are more side effects that have been observed, if risks are outweighing benefits, if the patient is actually due to have hopefully some pain relieving procedure like a joint replacement or a spinal decompression, intolerable side effects, and obviously some of those red flags about if the patient may be diverting their medication, which probably applies to a very small percentage. Really important to bear in mind that if a drug is working, then you have to be very circumspect about deprescribing that. It shouldn't be what's called a forced taper, which is a really important lesson to learn from the States, from the CDC, and the significant proportion of patients were then driven into the community buying illicit drugs like carfentanil, fentanyl, and using those. And patients' mental health can unravel and destabilize if they are functioning on low doses. Next slide, please. Really nice picture here from NHS Scotland illustrating the complexity of chronic pain. Medication's just playing a very small part in that overall jigsaw. Lots of other aspects of quality of life, daily function that need addressing. And it's really important, that's why chronic pain is delivered by a multidisciplinary team with rehabilitation. Next slide, please. It's complex. Acute pain, more of a linear response. Opiates work in acute pain post-operatively in the vast majority of patients. In our chronic pain patients, lots of other factors, psychological, social, physiological, that have an important role to play. And there really is a poor evidence base which supported those NICE guidelines that came out about harm and lack of efficacy of the medicines. Next slide, please. Another slide emphasizing the harms associated with medication. This was a survey sent to all the dementia leads throughout NHS trusts. You can see, not surprisingly, some of these drugs are in red. These are the high-risk drugs that we try and avoid. So nefapam, tramadol, or tramadont as we call it, dihydrocodeine, codeine-based analgesics, whereas a lot of people feel more comfortable prescribing things like buprenorphine patches in the elderly, which has a considerably safer profile, although we should still be very cautious about long-term effects. Next slide, please. Let's not forget the problem with driving and drugs. Next slide. So there's an onus on the patient not to get behind the wheel of the car if they feel impaired. Imperative for the prescriber to actually emphasize the importance of that. And there's some really good advice about driving on the faculty of pain medicine, and also other factors like sleep apnea that can become unmasked on sedative medication. The British Thoracic Society gives some really good advice about driving, and if you're cognitively impaired or you're not up for the job, and that's really important to get across. Next slide, please. You can flick through this quite quickly if you want. There's lots of bullets here. Could you flick through that really quickly? So lots of different causes of neuropathic pain. We're now seeing a lot of patients who are cancer survivors who are effectively chronic pain patients who've been cured. Clearly a role for some of the anti-neuropathic medicines, and then we need to balance up the risks and benefit with those. It's important to highlight that a lot of this pain is not responsive to opiates, and this is where the gabapentins, pregabalin, amitrip, duloxetine, etc. have a role to play. Next slide, please. This is a slide that comes out probably every 5 years. It's looking at the numbers needed to treat. So in terms of realistic expectations, a success for a medication in chronic pain is a 30 to a 50% reduction of pain. I'm just reiterating what one of the early speakers told us. And as you can see with those circles, the size of the circle represents the number of studies that have contributed to the data. And the slides have moved, the circles have moved further and further to the right. That suggests that the medication is less effective over time. So when we look...
Please could everyone make sure they have muted their microphones, please? Thank you. Sorry, Richard. Thank you.
I'm used to heckling, so that's all right. It's no problem. So an NNT, basically, how many patients do you have to treat to get a response for one? A low NNT, which you can see TCA's amitriptyline is great for diabetic neuropathy, not much else. The problem with gabapentin and pregabalin, which we have become reliant on using and have been made by Pfizer, which is probably one of the most successful drug companies, is over time that data for evidence of efficacy has slipped. So we're now having to treat about 10 patients to get a result in one, and that significantly undermined the role of the gabapentinoids. And we now have concern about those drugs being misused and contributing to other side effects, particularly in combination with opiates. So there's a very much the pendulum has swung away from using some of these medicines. Could we go to the next slide, please? Just a latest review from the BMJ a few years ago. I'll go through these quite quickly, looking at pregabalin plus placebo, gabapentin versus placebo. Next slide, please. So there is a small evidence base for efficacy in particular areas: fibromyalgia, peripheral neuropathy and diabetes, and post-herpetic neuralgia. Next slide, please. Traded off with the side effects, and we can see that's not inconsiderable in both gabapentin and pregabalin, particularly in elderly patients associated with dizziness, falls, etc. Next slide, please. And also, let's not forget that a lot of our patients who may be presenting in an acute trust may well have a degree of renal impairment from acute kidney injury. So it's imperative on us as the medics and the prescribers to be mindful of the fact that they may not be able to clear those drugs, which can have a significant impact on sedation. So we must be watching those drugs very carefully and adjusting the dose as their renal function hopefully improves during their inpatient stay. Could you flick to the next slide? A nice summary from Cochrane, which came out a couple of years ago. Next slide. Bottom line is we should probably be adding duloxetine to the water supply if we've got chronic pain. Significant harms associated with amitriptyline, nortriptyline, particularly in the elderly. Next slide, please. And a nice little summary there of the fact that as medics, we need to be very mindful of the context in which we're prescribing. That's a French philosopher. I can't take credit for this. Doctors put drugs of which they know little into bodies of which they know less for diseases of which they know nothing at all. I think that's probably a reasonably good summary of the nice guidance on chronic pain from a few years back. Next slide, please. And I'm happy to take questions at the end for that.
Fantastic. Thank you so much. That was fantastic. I think reminding us that 30 to 50% is deemed successful in pain management. I think that's a real take home for me anyway, personally. So everyone, questions in the chat, and we'll go into Q&A at the end, but thank you. Thanks, Richard. That's fantastic. And we'll join us again with the Q&A. Thank you.
Okay, thank you.
Okay, so we're going to move on to the next presentation now. This is a recording. This is from Pip White, who is one of the professional advisors at the Chartered Society of Physio. Pip has done a recording for us. She is not able to join us today, but she has done a recording. So hopefully we're going to share that for you now. I shall hand to Yogita for this. So we'll just hang fire, and I can see there's questions around sort of where we're up to in terms of medications. I know Michelle's put some links in the chat, and hopefully Pip will also discuss that. So just hang fire for a second. Just check in with you, Yogita.
It's just loading.
Okay, sorry. Thank you. Just bear with us. Perfect. Thank you.
Thank you for inviting me to present at your webinar, and I'm sorry that I can't be with you in person. For those of you that don't know me already, I am Pip White, Professional Advisor at the CSP, and for the past 15 years I've held the portfolio for medicines and prescribing within the CSP. And for the past 2 years or so, I am now also joined by fellow professional advisor Rachel Wadlow as we work on this together. As part of our medicines and prescribing work for 2025, we want to continue to work directly with a variety of professional networks, and so this invitation is very timely, and I hope that it can be the start of a closer collaboration between the APPN and the CSP. Today I'm specifically talking about our work around controlled drugs, as we can guarantee it is the issue members will raise with officers when we're out and about. I want to update you, hot off the press, with the CSP's work for 2025 and how you can help us with it. I also want to set the future context of how the profession ought to be considering how prescribing sits within our profession, as there is a need to increase both the number of advanced practitioners as well as prescribers within current health policy. We are aware that members are generally understanding that the position we are in with CDs is beyond our direct control, and that solving this problem does not lie with the CSP and ultimately lies at government level, but nevertheless it is a cause of continuing frustration. This is about updating 2 pieces of law, and the slide that you can see here is a summary of all the steps that have to be completed to get the law updated. As you can see, it's a multifaceted process, and it's also fundamentally a highly political small p process. The work for the case of need and approval from NHS England has already been obtained, and you can see from this table where we are stuck. We are currently stuck waiting for a ministerial decision on whether we can take the recommendations of the Commission for Human Medicines into the second stage of the process. We've now been waiting for this for over 3 years. We've obviously recently had a change in government, and so we're hopeful that we can get things moving again, and the CSP is putting a spotlight on this for 2025 and launching a campaign to seek to unblock this. So what does this campaign look like? Well, firstly, it's important to realise that this is about getting a political process moving. Therefore, we need to align our work, our expectations and our asks in line with government policy and priorities. That is to say, this is a strategic level rather than work at individual clinical care level. We must be very careful not to appear self-serving, saying things like, "It's not fair, we should be the same as nurses, we do the same training," because frankly, messaging in that way falls on deaf ears, and we also run the risk of coming across as a whinging profession. That said, we do very much need to leverage what we know about the clinical impacts of this blockage in legislation and turn those experiences and frustrations into patient-focused stories that we can use as levers to pull on the current policy spotlights that the current government has. So at the CSP, we are planning to do this via a series of strategic direct approaches to various levels of government, and we are working on the messaging for that already using the knowledge and resources that we already have. We will update members on this work throughout the year. We also need your help, and we have a couple of direct asks. If you can help us, please contact us, and our contact details will be on the very last slide. If you live in the Bristol South constituency and are a prescriber and would like to join our influencing work and are prepared to take a strategic approach, please get in touch. This could also be a good CPD opportunity for your individual development. Can you help us create the patient stories? We want specific examples of barriers related to individual patients and the impact that that prescribing barrier has had on that patient. We want to know the stories affecting the patient who has had to see an extra professional because you couldn't prescribe pregabalin. We want to know the story of a patient who's had to remain on a dose of gabapentin and pregabalin longer than expected because you can't deprescribe it. We want to know if there's been a delayed discharge because you couldn't step a patient down from morphine onto something more appropriate. We want to know if there are examples of patients who haven't been able to return to work because their medicines haven't been optimised. I also want to give you now a bigger picture to help move your conversations away from individual clinical matters and give you the levers you need to make the wider arguments for increasing the number of prescribers in your workplace. This is also where you can influence locally and champion the profession using centralised messaging aligned to government priorities. And the three main areas of government priorities is moving from treatment to prevention, moving care out of hospital closer to home and communities, and switching from analogue to digital. So for example, expanding the uptake and use of prescribing within the existing workforce where a clear case of need exists can allow physiotherapists to independently manage more aspects of patient care, thus reducing unwarranted pressures elsewhere in the system. Where physiotherapists prescribe, this can reduce the need for multiple appointments or multiple staff involvement, cutting down delays and pathway lengths, which could translate to cost savings for the NHS, as well as safer and more effective patient care. Increasing physio prescribers can improve patient experience of services and where they access them. And yes, there are very clearly professional elements to job satisfaction and career development that come with adding another skill to your portfolio. With the ability to prescribe, physiotherapists play an important part in streamlining care. This makes care pathways more efficient, but also reduces the carbon footprint associated with patient travel and multiple healthcare visits, and so may result in lower overall healthcare costs. With the ability to prescribe, physiotherapists can intervene earlier in the course of a condition, potentially preventing it from worsening and requiring a hospital admission. And by prescribing appropriately in line with a patient's changing presentation as they move through rehabilitation, a physiotherapist prescriber may be able to reduce the length of a hospital stay, and shorter hospital stays can decrease the demand on hospital resources. And finally, prescribing by physiotherapists supports the NHS goal of shifting care from hospitals to communities by managing conditions in primary care or at home. And by reducing the need for hospital-based services, this is also cost efficient as acute services are more resource intensive. It's also important to understand the impact of health inequities on the need for physiotherapist prescribers. Health inequity often manifests as limited access to healthcare services, particularly in rural and socio-economically deprived areas. Physiotherapists with prescribing rights can provide more comprehensive care in community settings, reducing the need for patients to travel distances. Long waiting times for appointments and treatments disproportionately affect communities, thus exacerbating health inequity. Therefore, by having more physiotherapist prescribers, particularly for things like musculoskeletal disorders and long-term chronic conditions in both neurological, cardiorespiratory, as well as musculoskeletal conditions, our early intervention can prevent progression or manage the decline of these conditions. Everything that has just been said is amplified within specific populations such as the elderly, those with disabilities and non-majority ethnic groups, and these groups often have specific health challenges that are not always adequately addressed. Where a physiotherapist already has contact with these groups, adding prescribing to your toolkit may enhance your offer to these patients. Many physiotherapists may not appreciate the wider population profile within their locality, and I would certainly suggest it's worth finding out what your local ICB plans and priorities are. And you need to make your argument for investment in physiotherapy and prescribing services in line with and not against these priorities. And the ICB plans are generally freely available following an internet search. So ultimately, any decision to move to electronic prescribing rests with the organisation and isn't something the CSP can directly influence. Ultimately, this is all about safer prescribing, and any system that enables a comprehensive record to be kept to which all relevant healthcare professionals have access to enables a more holistic view of the patient's health status. You don't need to tell me that there are significant challenges with the use of technology within the NHS, and more widely, not least the problem that prescribing systems don't necessarily integrate with other NHS systems or systems used outside of the NHS. Whilst none of these I would suggest are directly within control of either the CSP or you as individual practitioners, what we can do is make the case that investment in technology can result in safer and more effective prescribing. So to sum up, I'd like to say thank you very much for listening, and I hope that our plans for 2025 relating to controlled drug prescribing are something that you would find useful. We very much need member help with this, and if you are able to help in the ways that I've suggested earlier, please do contact me or Rachel directly. And I've put our direct contact details here on this slide. I've also put the contact details for if you have any general inquiries that you want to contact the CSP with, or if you have any network inquiries. So thank you very much again for listening, and I look forward to working with APPN and all of you during 2025. Thank you.
So we're going to move on to the question and answer session now. So I can see we've got some questions in the chat. So if I can ask all of the speakers and Dave, who's joining us for the question and answer session, to pop their cameras on. We've got the first question, Di.
Yeah, we'll start at the top if that's okay. So first question, Alex, for you from the chat. So what are common beliefs that you find people have about their medications, and what novel ways do you use to help explore these?
It's a good question, and I think it was touched on in a couple of the talks. A lot of patients expect the medication to be painkillers. They expect the medication to sort of take away their pain and work quite quickly. I also find a lot of them aren't really aware that medication come with side effects as well. So again, it is important to explain side effects of medication when they come in to see you in pain clinic, or if you are thinking about a different medication, explaining that to them. What I have found helpful with a lot of patients who are on higher doses of opiates is explaining to them exactly how much that is equating to in oral morphine. And a lot of patients aren't really aware that a buprenorphine patch, say at 10 micrograms, is roughly about 24 milligrams of morphine. A fentanyl 12 micrograms is roughly 30 milligrams of morphine. They're not aware of that, and they're just the starting doses, really. So patients who are on higher patches just feel that it's a patch that they put on, and it's something they don't need to be aware of. So I think a lot of the time it's just making sure you talk to them, explain to them exactly what it is that they're taking, what that means, what the side effects are of that, and just roughly about the dose that they are taking. And I think that lastly, just to put on this, is people are worried about stopping it because they feel that their pain may worsen if they stop this medication. Even though they're coming in and saying that they're in pain and they need more because they feel that their pain is getting worse. Explaining to them that maybe this medication isn't working for you, so maybe we need to start titrating down or weaning down to see whether it is effective for you or not. And again, as I think Ruth said, is making sure that they're aware that when you do start to reduce, that you might feel some more symptoms initially, but is making sure you give it enough time to settle down before just jumping back up to the original dose. I hope that answers the question. Anyone else got anything to add about that?
Thank you, Alex. That's fantastic. Thank you. Okay, next question is an interesting question. So I'm going to pose this to Ruth, if that's okay. So a question from the chat from Katrina. So it's really around, have we considered a PGD for deprescribing at any stage for consultants for control of medications? So I've not come across myself a use of a PGD for deprescribing, so I'd be really interested in I'll start with you. Any thoughts around that?
So unfortunately, and actually it has been sort of asked of the specialist pharmacist service before. I suppose, unfortunately, and this is the thing with PGDs, they are sometimes sort of misunderstood by organisations, and they try and establish them in circumstances where they can't quite be used. I think the best way to describe it and explain it is if you imagine a PGD is much like a standard operating procedure, that actually the clinician that sort of signs off the PGD is almost, as it were, pre-signing a prescription of a particular item to be given to a particular cohort of patients, with strict, discrete inclusion and exclusion criteria. It's a specific dose for a specific reason. So although it's a great idea, and I can imagine and understand the frustration you must have about, the restrictions placed on prescribing and how much in real terms it'd probably be a really good workaround for that for the interim. Unfortunately, legally, it isn't possible. I'm afraid that legally a patient group direction is there as a preemptive order to supply or administer a medicine rather than prescribe one. So prescribe and deprescribe, unfortunately. So although it's a great idea, it wouldn't be possible to kind of establish that as an alternative route at present, I'm afraid.
Fantastic, thank you. Yeah, I would think there may be some governance issues with that, possibly. Fantastic, thank you for that. Next questions to Richard. So there's a few questions around duloxetine. So I'll just take one from Ruth Pritchard. So who's putting here that the side effects of duloxetine in bigger BD doses can be difficult to navigate. Do you have any tips on how to manage those, particularly on younger patients?
Yeah, thanks for the question. So the reason why I mentioned duloxetine is that came out very well with the Cochrane review compared with its contemporaries that we've used for a number of years. It's also worth bearing in mind that very rarely will a chronic pain patient just be on duloxetine. They may well already be on other antidepressants, and let's not forget things like mirtazapine, which is given to help sleep, or amitriptyline, and they may be taking some PRN tramadol. So there's potentially lots of interactions with some of the serotonergic pathways. So my understanding, particularly with younger patients, particularly young male patients, is there can be problems with sexual dysfunction, erectile dysfunction, etc., from some of the antidepressants. That's one of the issues. And a really good sort of strap line for chronic pain prescribing is to start low, go slow, so kind of titrating medicines up quite slowly. So that's usually a sound principle to work on before you're upping their medicines. Maybe, obviously try and set some goals. What are you hoping to get out of them? It's without doubt a really good mood lifter as well. So it truly is a 2-in-1. You don't get any mood benefit from amitriptyline in the doses that you're prescribing it. And the other thing that's really changed, certainly in my time as a chronic pain consultant, is the fact that gabapentin and pregabalin held so much hope at the outset 15-20 years ago when they first came out, and they've really been discredited now with the wave of evidence in much the same way that opiates have been discredited. So I've not seen that many side effects in my patient groups compared with amitriptyline. I am aware from having gone to a conference recently that the elderly seem to, as with most things, are exquisitely sensitive to the side effects. They can get drops in blood pressure. There is another kind of generic brand of duloxetine, I think called Yentreve, and the lowest dose for that is 20 milligrams. But sometimes the pharmacists at the hospital don't like you prescribing that because it's a bit more expensive. So that is another option. But of the bunch of medicines, again, I think we'd probably be thinking about duloxetine almost as a first line for a lot of neuropathic pain conditions, and particularly if there's a strong diabetic component.
Brilliant, thank you. And are you going to come in, Yogita?
That's fine. I was just going to move on to the next question.
Oh, okay. I was literally just going to say, just from what you explained, somebody put, could you explain why you said it should be in the water? But I think you've just done that by that explanation. So that's fantastic. Lovely. I'll hand over to you, Yogita.
So we've got a question just regarding from Ruth Pritchard regarding the number of physiotherapists entering advanced clinical practice in frailty, and how imperative it is that the same efforts are placed for MSK colleagues that we invest in the wider workforce for the older community. Have we got Dave on the? Is Dave Baker here? Does he want to answer that question and talk a little bit about a private practice perspective?
Sorry, I missed a bit about private practice. I'm just looking back up to. Sorry, could you read that again? Because I think I must have been looking at the wrong question in the chat box.
No, that's okay. So Ruth Pritchard has put with the number of physiotherapists entering advanced clinical practice in frailty, it's really imperative that the same efforts are placed for MSK colleagues as it's invested into the wider workforce that needs to be involved in prescribing safely to our older community. Could you talk about that from just a private practice perspective? You know,
from a private practice perspective. Sorry, in community physio in private practice, or
do you want
clarify that?
Do you want to jump in, June? Yes.
Yeah, hi, I'm Ruthie Pritchard. I'm an advanced clinical practitioner in frailty, respiratory physio by background, many years ago. And my question is based around the fact that a lot of the Chartered Society of Physiotherapy seem to have invested a great amount of resource and money into developing the first contact practitioners on the MSK side of the profession, which is by large, you know, the bigger workforce in terms of the CSP. However, there is a sort of cumulative number of physiotherapists from different specialities who now are entering advanced clinical practice in the community, not privately, in the community with either community enterprises or community local hospitals or acute trusts for that matter, or working within PCNs as frailty practitioners or frailty advanced clinical practitioners. And there is this sort of sense of increased frustration that we're effectively tied up to not be able to provide the best possible continuity of care for our patients because of the restrictions in controlled drugs. And there doesn't seem to be nothing in the horizon that is encouraging. For example, with many of my colleagues who are in a very similar boat to us, is what do we get out of the CSP when we don't feel that supported? I think this group is by large the most effective, and very grateful to have you all here to kind of share that. But my question was about whether the CSP is planning to invest a little bit more of their resources into developing the wider workforce other than just MSK physios, basically.
So thank you, Ruth. So we can take that question back to Pip at the CSP. I mean, obviously her presentation will be available on the webinar, will be available on the APPM website afterwards, but we've got a few questions in there about the CSP support and what members can do as well. So I think if we can take that back to her and we can get back to you on that, is that okay? Hannah, did you want to come in into that question, you know, with Ruthie's question as well and answer that?
Hi guys, sorry, I missed that. Could you just summarize what was said? Sorry, apologies. Was that about the controlled drugs again?
Yes, so the limitations.
So to be honest with you, I think I'm in a position of probably similar, is that I've got doctors around me all the time. So the only thing I would say, I mean, we're talking about safety, but sometimes the doctors don't know who they're prescribing the controlled drug for. So I think it's a bit of a counterintuitive kind of process, really, because they're saying it's we're not allowed to prescribe because of safety, but then I sort of there are doctors that say I'll sign it, but as you say, don't know the patient. But I'm very fortunate because I'm surrounded by doctors and consultants. Sometimes it is a bit of a, I've got to leave my post and go and find someone, especially because I work weekends as well. So I work alone at weekends. And that does come up a lot where, I've had to change, the CDs had to be changed, or, we're de-prescribing a CD. And that can be sort of, that's where I feel the limitation is. And yes, I hope that's answered your question.
it's just nice to share the frustration, I think.
Oh.
And it is a little bit different in the community, because obviously we manage the risk in a completely different scale altogether, and we do get to know our patients very, very well. And I find myself often initiating controlled drugs, and I will have to speak to out of hours GP, and you know, you can hear the frustration in the voice. You say, you just told me you know the patient, I completely agree with you, what is exactly that you're asking me? And you're almost apologizing for being a physio. I'm so sorry.
Yes.
You know, I do, but you know the patient, you are with the patient, you clearly know what you're doing. You have organized the out of hours district nurses to go and start the syringe drivers, blah, blah, blah. So basically you're asking me to sign off your assessment, which you clearly have completed competently. And they, you know, and then you can see incident forms coming in, and why did I waste their time? And it comes down to the fact that because I'm a physio, and it's embarrassing, and you do feel for your patient, and you do feel for your workforce, because if you were a nurse or a paramedic, you wouldn't never had that problem. And you know, and at the end of the day, you got a patient at the end of it, whose prescription is being delayed because there is that kind of glitch in the governance of it. And it just makes me very sad, because it's not just the acute hospital, there is a lot of very, very good physios in the community that do a tremendous work, and it is frustrating for our medical counterparts and other nurses that you know, share the workload, who can't, you know, you are in that sort of situation where you can't provide what is best for your patient. But yeah, no, lovely talking to you, Hannah. It's great to have you on board, and it's nice to see all the physios here as well.
Thank you, Ruthie, and thank you for your questions. As Yogita said, there's some great questions in the chat, which we will obviously take back to CSP and put on as Q&As on our website. Last question really for me, just before we close, just one for Hannah. I don't know if you're still there, Hannah. I think you may be. Really, just you are fantastic. Just really something that we'd noted in the chat around the frailty and some of the most widely used resources. So we talked about the stop-start tool. Just wondered if you had any sort of experience you could share around use of that. Do you use that for your prescribing practice? Is that something that's helpful?
Nothing. We do it on a daily basis. So I feel now I'm at the stage where I've sort of got my tacit knowledge in terms of what you prescribe and what you don't prescribe. So I don't tend to use it, but in the early days I did, definitely. And talking to a lot of the pharmacists, they use it as well, to go through what is safe de-prescribing and what is safe prescribing. I think what I do though is, because I'm lucky enough to be working acute, I have all the parameters around me. So I've got the beauty of, we'll try this medication, was for example an ACE. We've got the OBS hourly, we can have, you know, and I can de-prescribe at any time, that kind of thing. So I think that's sort of how I go about it really. And I've got we're constantly monitoring our patients while they're on these medications. So I sort of got that safety net really around me all the time, I would say. But I think if I was in the community, I'd be using that tool quite, you know, rigorously really. But I've got other people I can ask as well at any time. And I've got the amazing pharmacists that I'm always ringing and annoying. I'm surprised they haven't blocked me yet. So yeah.
Thank you, Hannah. Well, we've got another contact. We've got Ruth now, so we're okay. We can hassle Ruth. Ruth and Richard from Prescribing. I'm just going to come into a close now. It's just before 8 o'clock, so just 4 minutes before 8 o'clock. I'd really just like to thank all of our speakers, and I'm sure everybody would want to do that. I think we've had some fantastic presentations. It's, you know, a lot of attendance. It's clearly a topic for physiotherapists, you know, across all the specialisms, and there is a sort of ease and challenges in different clinical specialisms in terms of prescribing. So it's been fantastic to have this conversation. So just a huge thank you to all of our speakers. Also like to thank Melanie Parry, our APPN administrator, for supporting us with setting up all the webinar, all the polls, being really patient with us. So thank you, Melanie, and also obviously Yogita, and thanks again to all of you guys for coming. And before you do leave us today, if you could fill in the feedback form. This is in the chat. You'll see there's a Microsoft Forms in the chat. It's really helpful for us to get feedback from you to help us plan our future webinars, because obviously we're here as a network to support advanced physiotherapy practice across 4 countries, multi-specialism. So we want to make sure that we're providing what is useful to you. The webinar will be available, it has been recorded and will be available on the APPM website, hopefully within the next week. And also we can upload some of the resources today that have been put in the chat, which is really helpful. So thank you for that. Thank you. I was just going to go back to that slide. We'll keep posted for our future webinars. Within the APPN, we have developed some communities of practice, so to try and reach across and hopefully support, like I say, the advanced practitioners working in these different communities. We will be doing a launch webinar with more information around these, but and we'll probably be doing an update surveys to see your clinical specialisms. But you'll see here, I won't read them all out, but these are the communities of practice we've got to date in these clinical specialisms for physios across 4 countries, across Ireland. And it's really about networking with people within your clinical specialism, sharing resources. So it's going to be a great resource for people, as well as obviously the wider APPN network. So we'll keep you updated with that. But thank you once again to everybody. Fill in the questionnaire for us, the feedback form, and enjoy the rest of your evening. Thank you.